Thank you for joining us today for our webinar, What's the Big Deal About Xolair? What is it? And how does it reduce allergic reactions to food? I am Jennifer Gertz, Executive Director of Food Allergy Canada, and today our expert joining us is Dr. Sharon Chinthrajah. Before we get started, I want to note a few items. Note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. Thank you to everyone who submitted questions upon registration. There are some common themes that we will tackle in today's session. If you have additional questions during the session, please submit them in the question box throughout the webinar, and we'll try to get to as many of those questions as we can. And lastly, this webinar will be recorded and shared on foodallergycanada.ca afterwards. First, some background on this session today. In February of this year, the Food and Drug Administration in the US approved Xolair for food allergy as a treatment to reduce the risk of reactions to multiple foods based on the results from the OUtMATCH clinical trial. Some of you may be familiar with Xolair. This is a brand name for the medication omalizumab. It is not a new drug. In fact, it was approved over 20 years ago for specific patients with allergic asthma and for chronic urticaria. What is new is that it is now approved in the US for certain patients with food allergy. We really debated the merits of holding this webinar this soon after the US approval because Xolair has yet to be approved for food allergy by countries outside of the US, including Canada. And so for some in the audience who are expecting an answer today to the question of when is it available, it's early days and work is required, both on approval and drug reimbursement. So while we might be getting ahead of ourselves in offering this session, we have had many questions from the community on Xolair, and so we were compelled to connect you with the experts to share what is known about how Xolair treats food allergy, what can the treatment deliver now, and what's being investigated further to address unanswered questions and uncover all the possibilities this drug may have in the future. Today, we are very fortunate, truly fortunate, to have Dr. Sharon Chinthrajah, Acting Director of the Sean Parker Center for Allergy and Asthma Research in California, where she leads the team to conduct novel and impactful phase 1 to 3 translational studies in food allergy. What this means is she focuses on taking scientific findings and works on converting that into knowledge and actions that benefit patients and create choices for individuals on their approach to managing food allergy. Dr. Chinthrajah worked with Dr. Carrie Nadeau, a pioneer in food allergy research at Stanford, who established the Sean Parker Center, which Dr. Chinthrajah now leads. In addition to her medical degree from Drexel University College of Medicine, she has subspecialties in pulmonary allergy and immunology from the Boston Medical Center and is one of the principal investigators for the OUtMATCH trial. We have the expert on this topic. In today's session, Dr. Chinthrajah will walk us through the OUtMATCH trial that led to the FDA approval of Xolair and will provide perspectives on additional work that's being done. This will be followed by a Q&A, and at that time, I'll also outline for you the steps that are required for drug approval in Canada and the steps that Food Allergy Canada has taken thus far. I'd like to pass it over to Dr. Chinthrajah. Thank you for taking time out of your very busy schedule to be with us today. It's over to you.
Thank you so much, Jennifer, for this very kind invitation to share with you some exciting outcomes from the OUtMATCH study. It is truly my pleasure to join you all, and thank you for taking time from your day to tune in. So I have a few disclosures. I receive grant support from government agencies within the United States, the NIH, Food Allergy Research and Education. I'm also an advisory board member for different companies in the food allergy space, including Novartis and Genentech, who manufacture Xolair for allergic disease. So I don't think I have to tell you all the impact of food allergy. You may actually see yourself represented here. There's a huge social impact of food allergies on families. And research from our colleagues across the globe have really shown that this impacts every aspect of social life. 89% have avoided certain restaurants. 82% have changed family traditions to accommodate food allergies. 53% have skipped out on an important school function. 45% have avoided airline travel. Um, there's been reports of bullying at school based on the particular child's food allergies. And there's no doubt that this creates tremendous anxiety for the patient with food allergy, for the family member caring for the food allergy, for a friend who's caring for one of your children's playmate who might have food allergies. It's also a costly chronic disease. In the US, it's estimated to cost $25 billion per year, $4,000 per child per year. This is old data from 2013 from our colleague Ruchi Gupta. And really, it's about all of the different things families with food allergies have to do to be safe, which includes carrying epinephrine autoinjectors, carefully sourcing foods and snacks that are safe, and perhaps emergency room visits or doctor visits to diagnose and manage food allergies. So in the U.S. And North America, there's the top 9 food allergies, which include peanut, tree nuts, milk, egg, wheat, soy, fish, shellfish, and sesame. And not surprising, many of our food allergy patients are allergic to more than one food. And actually have more than one allergic condition. So 30 to 40% of patients with food allergies are allergic to more than one food. Roughly 2/3 of those patients with food allergies also have an allergy, another allergic condition, such as eczema or asthma. How do we diagnose food allergy? This is important because these are the tests that are available in some research settings, in some clinics, and in clinical labs. And the way we prove somebody has food allergy is also the way that we can monitor response to any therapeutic that we initiate or start in our food allergy patient. So here I'm listing some of things that you can see in your clinic, you've probably experienced yourselves, and things that are perhaps more available in research centers with hopes of becoming more available to clinics more widely. So I'll start with oral food challenges. The advantage is it's the gold standard. There's especially when it's done in research settings as a double-blinded food challenge, which means that there's placebo doses or a placebo day for the food challenge to help us distinguish between a true allergic reaction and symptoms of anxiety associated with the knowledge that we're introducing these foods that somebody's allergic to in very small amounts and introducing more amounts of that food over time and observing for allergic reactions. It's stressful, it's time intensive. There's obviously a risk for an allergic reaction. There's also skin prick tests. These are standardized. These are relatively fast, but sometimes we have false positives, meaning that if you're a highly allergic individual who has other allergic conditions like eczema, you may have a lot of allergic antibodies, IgE antibodies, and that can lead to positive skin prick tests, which are testing these allergic antibodies on mast cells that reside in your tissue to understand if they're is recognition of the thing that you're testing to. So this is a common test that we use for testing for tree pollens and grass and environmental exposures as well as food. Then there's allergen-specific IgE. This is a blood test. It also has some false positivity in highly allergic individuals. Then there's the basal activation test. This is a research lab and requires it requires a blood sample and fresh blood and processing within 24 to 48 hours. So there's some limitations that researchers are trying to overcome. There's mast cell activation tests, which uses components of your blood, particularly plasma, which has the IgE antibodies, and uses that on a different cell line. This is great because it doesn't have that 24 to 48 hour requirement for testing. And then there's bead-based epitope assays. There's one that's available for peanut in the United States, and it has been used for diagnosis of peanut allergy, and gives us a sense of threshold sensitivity. Do you react to very small amounts? Do you react to very large amounts? And I think they are working on other allergens as well. So management of food allergy, most of our food allergy patients actually do allergen avoidance. There's always a risk of accidental exposure, even in the most careful families, because we are human and accidents happen. Allergen avoidance is challenging and expensive. It can induce fear and anxiety, not only in the patient, but in the family and people who love the patient who has the food allergy. We also use epinephrine auto-injectors. This requires training. We actually have to carry it, have it on hand in case of an allergic response. And data shows that we're not really good at doing that. 9.2% of children, actually less than 50% of children and adults who have a food allergy diagnosis actually carry an epinephrine auto-injector when they're eating. And then 9 or 10% of patients who have a food allergy and have been carrying it have actually had to use that. So let's dive into biologic therapeutics and omalizumab or Xolair. So this is a biologic. What does that mean? These are therapies that are produced in living organisms, cell lines, etc. They target the molecular mechanisms of allergic disease. This is a very busy slide or picture, but let me orient you to this is your epithelium or your skin surface. And this epithelium is the surface lining of your respiratory tract, your GI tract, your skin. And it is the first face of interaction with the external environment. So it interacts with allergens, injuries, stressors, etc. Underneath that is where you have immune cells that can actually sneak through that barrier, that epithelium, and interact with the environment and be the first signals that start an allergic reaction or a tolerant reaction. And in those signaling, the way that cells communicate with one another to start an allergic reaction is through cytokines. And this is what you're seeing here. These cells talk to each other and they ultimately lead to the production of allergic antibodies or IgE antibodies. And omalizumab or Xolair is an anti-IgE. And this is what I'll be talking about in more detail. It's the first biologic really that's been studied in food allergy. It's been around for 20 years for other allergic conditions like allergic asthma and allergic rhinitis and idiopathic urticaria or hives. So I'll dive into the OUtMATCH study. This is omalizumab for the treatment of multiple food allergies. The list of authors here is just a small fraction of the team that was involved in this study. It was originally um, uh, brought up as an idea in 2017 as a grant idea from the Stanford group, and really evolved over time with lots of input from the COFAR investigators, the NIH, and partnership with Genentech and Novartis in trying to take the early data that had shown promise of omalizumab for treatment for people with a single food allergy and multiple food allergies, and how could we really get it to a point where this was available outside of the research setting. So it is a complicated study. It has 3 different stages. I'm really going to focus on stage 1, which is what has recently been published in the New England Journal of Medicine in March. And so 435 individuals were screened, ages 1 to 56-year-old, 1 to 55 inclusive. We were looking for patients who had peanut allergy plus allergies to 2 other foods and they could choose from egg, milk, cashew, walnut, hazelnut, and wheat. There were a lot of folks who didn't meet this very strict entry criteria. We were looking for a very allergic patient population. So some were not allergic enough, some were not allergic to peanut, which had to be, the first allergen that was included. Some had poorly controlled asthma, some had a history of anaphylaxis and were excluded. Um, and ultimately, 180 individuals were included, 177 who were children, and that's the focus of the manuscript. There were 3 adults, but we really focused the analysis on the bulk of the children that were included. They were allergic to peanut plus 2 other foods, and then they were randomized to receive omalizumab or Xolair, um, or placebo injections for a period of 16 weeks, 16 to 20 weeks. Um, and then of the 180 individuals, the first 60 went into an open label extension where they received additionally 24 weeks of omalizumab. This one, we knew that they were receiving the real drug to look at longer term use of omalizumab in our food allergy patients to look at the durability of response. As I mentioned, this was performed at 10 sites across the United States and involved massive effort of the teams at each of these sites, plus the patients. So I mentioned that the study design started in 2017. The study actually started in 2019, where we enrolled our first patient. It went through the pandemic, and our patients were so vested in this study that they hung in there with us when some patients you know during the pandemic, as we all remember, there was shutdown of a lot of sites, a lot of research activity. Some patients had to restart. And so it's a true testament to the patients of this study that they really believed in this treatment option and the research that they were doing and the critical need for therapies for food allergy patients. This is another look at what I just showed you. But really what I wanted to highlight here is that ultimately 177 patients went into stage 1. They went on to omalizumab or placebo injections for 16 to 20 weeks. The first 59 children went on to receive open label omalizumab for 24 weeks. And then we have those patients who completed. So what did we see? We saw really great results across all of the foods. And what I'm showing you here is very busy, but these are all the foods that were studied, and I have the next few slides will actually focus on four of the foods in particular. But what I want to draw your attention to is the doses of the food challenge. So each of these patients had to undergo a food challenge to peanut plus two other foods plus placebo before they started the study, and then after the 16 to 20 weeks of injections. So 4 food challenges at the beginning, 4 food challenges after the first stage, and then again after 24 weeks of the open label extension. This data is showing you the data at the food challenges conducted at after the 16 to 20 weeks of treatment. These doses here on the x-axis are kind of how we do food challenges. We do small doses with increasing amount over time, really carefully observing for an allergic reaction. And on the y-axis, we're showing you the percentage of patients who actually consumed or ate that dose without an allergic reaction. I'm showing you peanut, egg, milk, cashew, walnut, hazelnut, and wheat. The gold bars are the patients that received omalizumab. The blue are placebo. And I'll break this down in slides. It'll be easier to see. But what's striking here is the clear success of those patients who received omalizumab. The gold bars are quite high. And the further out we go here on the x-axis is the amount of food that they were able to consume. So let me take you through that, because I think this is really what we were hoping we would see, and what actually bore out in a phase 3. The reason we do phase 3 studies is to build on the data from the phase 2 studies. So there had been a lot of phase 2 studies at Stanford, at other sites, other COFAR sites, where there were smaller numbers of patients, maybe just at that site or maybe at a few different sites. A phase 3 looks at a larger number of patients across a diverse geography, and really trying to see, okay, is this something that we can say that works for most people with food allergies? What we found is 67% of patients could ingest 600 to 1,000 milligrams of peanut. 1,000 milligrams of peanut equates to 3 to 4 peanuts. 64% could eat 2,000 milligrams of peanut. This is the protein, so this is not the weight of the food on a scale. That's about 8 peanuts. And still over a half, 57% could eat 4,000 milligrams of peanut. That's about a tablespoon of peanut butter. All of these patients were really allergic at the beginning of the study. They reacted to doses that were a fraction of 1 peanut. So here we have a treatment option that can change your threshold sensitivity to peanut, for instance, from less than a half a peanut, even, probably a tenth of a peanut, to 3 to 4 peanuts, or even amounts that would equate to 20 peanuts, which I'm not showing you here, but all in the span of 16 to 20 weeks. We saw similar rates of desensitization for other foods. Here I'm showing you egg. 73% could eat 1,000 milligrams of egg. That's roughly a quarter of an egg. 2/3 could eat about a half an egg. More than half 55% could eat about 1 egg. Here I'm showing you milk. 71% could eat or ingest 1,000 milligrams of milk, which is 2 tablespoons of milk, without allergic reactions. 2/3 could ingest about a quarter cup of milk. 61% could ingest half a cup of milk or the equivalent. These were all given in food flours that were manufactured from Stanford and distributed across the different sites. So we're not actually, I'm converting this into food equivalents to make it relatable, but in the study, it was actually food flours, and this is how we were able to be blinded. So the investigators didn't know what the patient or participant was receiving, and neither did the participant. Here I'm showing you cashew. Now, cashew was a little bit different. Only 47% could ingest 1,000 milligrams of cashew without an allergic reaction. That's about 3.5 cashews. 41% could ingest 7, and a third could ingest about 15 cashews. It turned out that patients with cashew allergy were actually quite sensitive to cashew. They reacted at very small amounts, smaller amounts than peanut or the other foods. And actually we defined success for the study as meeting this endpoint of 1,000 milligrams for cashew, whereas for peanut it was slightly lower. And that's because we defined allergy differently for peanut versus the other foods that were included. And so we were a little bit more stringent about peanut and less stringent about the other foods. And mostly because we wanted to be inclusive. We didn't want to get a very, very, very severe multi-food allergic patient population that is unrealistic. And it turns out in reality that the patients were quite allergic, were very sensitive at the baseline, and were able to change their threshold across foods. So this is another different look at the sensitization for the different foods. Here I'm showing you peanut. Again, the threshold for being successful for peanut was 600 milligrams, so 2/3 actually met that criteria. The other foods like cashew, egg, milk, walnut, hazelnut, and wheat had to hit the threshold of 1,000 milligrams. All of these amounts that I'm talking about as 600 or 1,000 milligrams, what does that boil down to in real life? These are amounts that we think would be above the amounts for these foods that would probably be encountered upon an accidental exposure. So that's how we try and design clinical trials, of thinking about how does this relate or equate to real life and real life exposures. Importantly, we studied a multi-food allergic patient population. So we have data actually on not only how they did for each of the allergens, but how the individual did across 1 food, 2 foods, and 3 foods. And here I'm showing you the proportion who could ingest various different amounts of the foods. Red is 1 food, blue is 2 foods, 3 is 3 foods. And we see that patients can ingest about 47% can ingest 1,000 milligrams across 3 foods. So that third food is a little bit troublesome. Roughly 70%, 69% can ingest 2 foods without any problems. These are at levels of accidental exposures. There are some patients who did really well across 3 foods. So if we look at 4,000 milligrams, and there was even 6,000 milligrams, which I'm not showing, 75% of patients could tolerate 4,000 milligrams of 1 food, 54% could tolerate 4,000 milligrams of 2 foods, and 31% could tolerate 4,000 milligrams of 3 foods. So clearly there's some variability across our patients and their reactions to individual foods as an individual, and then patients and as a group and how they react. And so I think that there's a lot of questions there that are left to answer. I want to switch gears and talk a little bit about the safety of omalizumab in this study. It was quite safe. As we expected, there was nothing unexpected that we uncovered based on the long safety data that we've had of omalizumab or Xolair in other allergic diseases over the last 20 years. Roughly 23% of omalizumab participants had some sort of adverse event compared to 15% of placebo participants. The majority of these were injection site reactions, so erythema or pain. 3% had hives, 3% had hypersensitivity reactions. So to summarize, 16 to 20 weeks of omalizumab allows 2/3 of food allergic individuals from having allergic reactions to 600 milligrams of peanut and 1,000 milligrams of other allergens. Omalizumab showed similar levels of protection against most allergens tested. Cashew was notably lower, I think, for the reasons that I went into than other allergens, but actually improved with more time on therapy. So I didn't show you the open label extension, the additional 24 weeks, but we did see that the patients, more cashew participants could tolerate 1,000 milligrams with those additional 24 weeks on therapy. So we were very excited that this study was a major driving force that led to the FDA approval of omalizumab for food allergy. And in blue here, I've copied what has been the actual approval. So it is now approved for IgE-mediated food allergy in adult and pediatric patients age 1 year and older for the reduction of allergic reactions, including anaphylaxis, that may occur with accidental exposure to one or more foods. It's to be used in conjunction with food allergen avoidance. So I'll take a pause there just to digest that. I think we're super excited that for the first time, the study was able to show omalizumab safety and efficacy data in children as young as 1 year of age. Previously, omalizumab had been approved for allergic conditions for 6 years and older. So this is the first time we're having a good look at the safety in 1 to 5-year-old patients. It's approved for children and adults and approved for one or more foods, which is very exciting. And not limited to the number of foods or the specific foods that were used in the OUtMATCH study. There were previous phase 2 studies conducted at Stanford where we looked even at 15 different foods and food groups, and there are other studies in Canada and in the US that are ongoing, which I'll talk about in a little bit, that look at other foods. But I think this is really a great step forward and a really important indication for our food allergy patients because as we know, there's the top 9 foods, but then there are other foods that don't fall into that category. So because of the underlying biology of food allergy, we believe that this anti-IgE should be effective across a variety of different foods. The indication from the FDA is that it must be used alongside allergen avoidance. It should not be used in individuals who have a history of allergic reactions to omalizumab or its components. So what does this mean in the clinical context now that it's FDA approved in the US? At least in the US, we're thinking about it. There are prescriptions that have been written, patients that have been started since the FDA approval on February 16th. And the practicality of it is that it is given as a shot every 2 to 4 weeks. There is the potential for at-home self-injections in the right patient population. It provides simultaneous protection against multiple allergens and other allergic diseases. So as I mentioned, oftentimes 2/3 of our patients have eczema and asthma and food allergies. And so here we are with potentially one drug that might be able to address all of these allergic conditions. Other therapeutic options such as oral immunotherapy offer specific protection for that food, but may have a higher treatment burden. What about managing the burden of treatment of omalizumab? So I think we definitely need to manage expectations. It is an injection, and this is not for everybody. How can we overcome some of the fears of injection site pain and reactions? So at our clinic, we use these buzzy bees. We try and trick the nerve fibers to have a sense of vibration. We use ice so that the nerves are focusing on a temperature of cold and a vibration sensation. To minimize the alertness of the pain factor. And then there's also lidocaine creams that can numb the skin and can be helpful for particular patients. And then, as is often the case with many therapeutic options for children, there's the balance of rewards and incentives for being brave and you know, changing a course of disease. Um, Omalizumab does not replace your epinephrine autoinjector. So omalizumab is given as a preventative treatment to prevent allergic reactions upon accidental exposures. It has to be given for a little bit of time before it's actually effective. Epinephrine is a reactive treatment. If we make analogies to the asthma world, we think of controller medications and rescue medications, right? So omalizumab falls into the controller medication, epinephrine falls into the rescue medication. Epinephrine is given after an exposure to the allergen, helps us stop allergic symptoms. It's a reactive treatment. So omalizumab should not be given as a replacement for epinephrine. Food allergic individuals who start on omalizumab should still carry an epinephrine autoinjector. Some of the limitations. So omalizumab protects against food allergy, but it's not curative. This is something that needs to be taken for a period of time. The degree of protection varies between individuals. There are differences in the degree of protection to different allergens in the same individual. And we don't currently have good biomarkers or tests to understand um, who is the best candidate for this therapy and who's actually responding. Food allergy is a chronic disease requiring long-term treatment. So, how do we monitor response with omalizumab? I come back to the same way that we were diagnosing food allergy. And really, omalizumab is binding circulating IgE antibodies in the blood. So, we can't test the IgE antibodies in the blood because we may get false results. We may be picking up the antibodies, the IgE antibodies in the blood that is actually bound to omalizumab, but not really effective and leading to allergic reactions. Skin prick test can still be positive. The effect of omalizumab takes longer to see in the skin prick test, and that's because mast cells that sit in our tissues live there for a longer period of time. They don't circulate. Basophil activation tests might be helpful. Those are circulating cells, and so we think that we should. We've seen in other studies and in OUtMATCH that this does the reactivity of basophils as an immune cell does go down with omalizumab therapy, but it's not widely available. And so, really, the oral food challenge is the thing that's currently available. And this is something that needs to be balanced with the commitment of time and probably the only real way to understand if the patient is responding to omalizumab. And this is where shared decision making is really going to be crucial in understanding which patient populations to do that for. So a lot of open questions. How long do we need to treat for? What about patients with really high IgE that actually don't that didn't qualify. So that was some of the screen failures in the OUtMATCH study. Um, and how do we address that? Can this be used in combination with other therapies? Will we be able to introduce real foods into the diet? What markers can be used to predict response to omalizumab? What would a better therapy look like? So I'll close with just some of the other things that are going on still as exciting research questions that are ongoing. So the stage 1 therapy is really looking at omalizumab by itself, just injections, and that's what I've showed you. Previous studies have really looked at omalizumab in conjunction with oral immunotherapy. What I'm showing you here is kind of what that study schema looks like. For the multi-food allergic individual, this is really work that was pioneered by Kari Nadeau and Tina Cinder, has been involved in a lot of these studies from the Stanford side. So we use omalizumab for 8 weeks just by itself, and then we introduce food in oral immunotherapy, and we keep stepping up for the oral immunotherapy desensitization, and then we stop omalizumab and continue with food. The studies that look at this have different study designs, but this is kind of what the schema looks like. The purple line is um, the patients and kind of the escalation of the food with omalizumab. The blue is without omalizumab or Xolair. And so what's quite obvious is that if you have omalizumab on board, you can actually ramp up with oral immunotherapy quicker. You can make larger jumps in the dosing. And we've seen that that can be done safely in phase 2 studies. And then we can test for desensitization and sustained unresponsiveness, a period of avoidance. Meta-analyses have shown that omalizumab improves multi-allergen oral immunotherapy, so the safety and the speed of that desensitization process. It also improves patient quality of life in this meta-analysis. And the OUtMATCH study has 3 stages, so this is some of the things that we are looking at, which is still ongoing. And that's stage 2, where we're using omalizumab facilitated multi-allergen oral immunotherapy versus omalizumab with placebo. And that treatment period is for 1 year. And then stage 3 is dietary introduction of the foods that the patients have been allergic to, following stage 2 or open label extension. Stage 3, and we've published our food equivalents in Jackie in Practice early last year, is really about real food equivalents. So for those patients who went into open label extension, and they actually bypassed stage 2 and went straight into stage 3. So there are different combination approaches where you can have omalizumab with oral immunotherapy and some bridging there, or omalizumab followed by real life food equivalents, the way it was designed in this OUtMATCH study. And those are results that will be forthcoming. In Canada, you all have the BOOM study, which is looking at omalizumab to accelerate symptom-driven multi-food allergen oral immunotherapy. And this is still enrolling, and the PI is Dr. Phil Bejan. Across different sites. It's really assessing the efficacy of 2 different doses of omalizumab. So there's still different questions. We use one dosing algorithm for the OUtMATCH study, but perhaps there's a better dosing strategy that would have a higher rate of success. And this is under investigation in the BOOM study. We have the combined study that's being conducted in California. This is actually combining different biologics with multi-allergen oral immunotherapy. So omalizumab and dupilumab with multi-allergen oral immunotherapy. And then there's more to come. How do we put this all together? There's food specific therapies like oral immunotherapy, which I briefly touched on, sublingual immunotherapy, epicutaneous immunotherapy, the patch, modified allergens that might be injections or infusions, and then different biologics. So I talked a lot about anti IgE today. There's things that target those allergic inflammatory pathways higher than that. And within cells, there are things that are in development to look at your microbiota and how the bacteria and different organisms that live in your gut can influence the way you react to foods as well. So there's a lot of excitement about how we can improve upon what we have. And there's certainly a need for better strategies. So, how will we use biologics, and how will that affect patient management? It may biologics by themselves, and I'll say omalizumab may provide an alternative to allergen-specific immunotherapy, particular for patients who are allergic to more than one food. You may have higher compliance allergen-specific therapy, whether it's oral immunotherapy or sublingual or EPIT, require daily treatment, daily options. There might be less adverse events. It may be less time consuming. It could, in the future, be used as an adjunct with allergen specific therapy to reduce adverse events, improve treatment outcomes, improve durability of response, and maybe some of that might be age dependent. Because we know that we're diagnosing food allergy in infants now, following our early introduction guidelines and advice across the globe. And while we may be preventing food allergy in many by introducing foods early, we are not preventing it completely. So there is still a need for better therapeutic options for all ages. And some of these therapeutic options may have better responses in different age groups. So I think that that is really important to understand as we move forward. With that, I am happy to take questions. I thank you so much for your attention and for your time. And I'm looking forward to the dialogue.
Great. Thank you so much, Dr. Chinthrajah. I'm going to ask you to turn your camera on, and I'll turn mine on as well. And we've got a few minutes remaining for questions. So there was a few questions that came in that in advance of the session, but also some throughout the session. And I'd like to start with the target patient. So right now, with how Xolair has been approved and what we know today, not all the great studies that are helping inform how that might change in the future, from your standpoint, who is the target patient that's best suited to what Xolair has to offer?
Yeah, I think this is a really great question. And if you asked 10 allergists, you would get 10 different answers.
Okay,
Ultimately, I am excited about any new therapeutic option for our food allergy patients. This is something I think in my own patient panel, people who have multiple food allergies, this is a great option. Patients who have um, asthma or eczema and food allergies where it's been difficult to control one or more of their allergic conditions, this would be a great option for them. um, and I think patients who've tried oral immunotherapy and have not been successful for whatever reason, this would be a great opportunity to try this therapeutic approach. There's
okay,
a lot of nuances in there, and I treat other allergic conditions. I treat asthma. I treat uh, allergic rhinitis, right? And there are expensive biologics, which this is, And there are non-expensive daily medications. And ultimately, it's shared decision making between the patient and the provider and the burden of treatment. What is so burdensome for the family? But,
Mhm.
it's balancing the burden and balancing the risk, right? For patients who've had multiple allergic reactions and are just allergic to one food, I still think that this is a great option for them because we're talking about um, adding another layer of safety in addition to careful avoidance.
Great. Okay, thank you. So now just a couple of quick questions of clarification that came through. When we're talking about multiple foods, we often put tree nuts in as one food, okay? But is it actually something that you're looking at individual tree nuts that actually would qualify as multiple
Yes.
food?
Yes. Individual tree nuts um, are each considered individually.
Perfect. I just turned off my camera. I just noticed it was freezing, so I'm going to turn that back on again. We have these technical difficulties, but everybody understands that. So, on the question of how to assess whether Xolair is working, you took us through kind of the various different processes for diagnosing, and that is one of the ways for monitoring its effectiveness. So, if someone who was on Xolair accidentally ingested their allergen, would there be something in their system that would trigger them to stop? Or how would they know to stop actually eating the food?
That is a great question. So oftentimes I think of our food allergy patients of having spidey senses, right? Their senses are heightened to detect the foods that they're allergic to, either by smell or by a sensation of itching or tingling in their mouth. Babies kind of describe it as like spiciness, or they put their hands in their mouth because there's some itching sensation, and then kids and adults can actually um, tell us in words. But sometimes that's a signal, and I don't necessarily think that omalizumab takes that away. So I think you may be able to still detect that you've had an accidental exposure, but maybe over time that might also fade. We don't know.
Right.
Yeah.
Okay. Now, you alluded to wanting to understand with future work and the current studies that are underway on whether there's better efficacy by age. But is there anything that's been learned in the OUtMATCH trial that would suggest that there's better efficacy right now in younger children, or is that inconclusive at this stage?
No, that's a great question. This is one of the things we actually looked at because we were very lucky to have more than 50 kids in that 1 to 5 year age bracket. And we see similar efficacy if we break it up into kind of that young toddler age period, and then younger children. So 1 to 5, 6 to 12, 13 to 17, and it works equally effectively in those three kind of groups of
Okay.
children. Yeah.
Terrific. Okay, let's go on to epinephrine and Xolair. Okay, so the indication that's been approved in the US says you still need to carry your EpiPen. So people might be asking, or your Allerject, whatever your device of choice is. So can we just go through kind of the differences between an auto injector and Xolair, and also why the indication still suggests that you have to continue to avoid and carry Epi?
Yes. Epinephrine auto-injector is still a needle, but it acts very quickly. It gets, because of where we deliver it, and the medication itself, its effect happens within seconds, right? We say that you should always carry a second auto-injector because if we don't see improvement in symptoms within minutes, we say use another one, right? So it's a very rapid onset. It's meant to treat an allergic reaction. In fact, if you've had an accidental exposure, some providers, depending on a patient's history, may say if you recognize you've had an accidental exposure and because you have bad allergic reactions, you should use the epinephrine auto-injector, right? Omalizumab doesn't work quickly. Its half life is 21 days. To get to full therapeutic response in other allergic conditions, we talk about months. Here the earliest point we're testing is 16 weeks. Um, and so it takes a longer time to start, and it doesn't work that quickly to really cut an allergic reaction because it's a different biology. The reason that we still recommend patients carry an epinephrine auto-injector is because we don't have a great tool to assess who's a good responder and who's not.
Okay.
Yeah.
Okay. Okay, great. Let's talk about long-term use and safety. There's lots of questions that came up around, going beyond the side effects to kind of the long-term safety associated with using Xolair. What can you tell us about that? I mean, it is a drug that's been around for 20 years, but maybe you can give our audience some perspectives on the safety profile.
Yeah. So, as a pulmonologist, I have a severe asthma panel, and I have a lot of patients on biologics for a really long time. There's great colleagues who also have looked at this in longer term studies for pediatrics, which I think is on everybody's mind about long term use of this medication in children. We don't have long term efficacy data in the 1 to 5 year old patient population. I don't expect that it would be different than the 6 to 12 or the 12 to 17 or the adult data. Um, and it's a very safe drug. The majority of the adverse events are really injection site reactions.
Okay. Okay. Terrific. Thanks for that. Now, I just want to quickly talk about path to approval. We've just got a couple minutes. Is it okay if we go a few minutes over, Dr.
Yeah.
Shinta? Okay. Perfect. Okay. So I know a bunch of questions came in about what the path to approval here is in Canada and to reimbursement. And so I just wanted to clarify for the audience the steps that need to happen here. First off is we have to have a manufacturer submit to Health Canada for regulatory approval to sell and market their drug. That's the first step that happens. They also make a submission to the Canadian Agency for Drugs and Technologies in Health, and then that body reviews that drug and does a health technology assessment, and a recommendation is then issued on whether or not the product should be publicly funded. From there, there's a price negotiation that takes place if the products have received a positive health technology assessment recommendation, and then there's discussions with the provinces around whether they will take that response and put it into their public drug program. So to date, we've had some initial meetings with Novartis to understand their plans here for submitting for market authorization. And we've also made an outreach to Health Canada to understand the process and possibility for fast tracking. So we've taken those steps. So I want everybody to know that this is not going to be an immediate piece, but it is something that's underway. We do recognize that as part of this process, we may need input from the community through this approval process. And we would encourage you to fill out our post-webinar survey, because we may need to reach out to some of you who've had some experience with Xolair, perhaps through clinical trials, so that we can be able to provide our regulators with patient-reported outcomes on those things. So now I want to leave the very last question to you, and then we're going to go back to the poll. So, as a clinician and researcher, what does it mean to have Xolair approved? Like, just help us understand that. I know when this got announced at the American Academy meetings that there was a standing ovation, but give us a sense from your perspective on what this might mean to the community and the future of food allergy treatment.
Well, thank you for that question. For me, it's super exciting. I mean, I started at Stanford 10 years ago. We were doing only phase one, maybe phase two studies to see the growth of interest in treatment options for food allergy patients over the last 10 years. It's been exponential. It takes a long time for a therapeutic to go through research to get to this point in time where you have an FDA approval and it is available in the clinics. So I received so many messages from patients who had participated in earlier trials, from colleagues who have children or family members with food allergy. Um, just saying, my gosh, finally we have something that we can use to manage our allergic reactions. It's a drug, I think, that will really change the way our food allergy patients interact in society. There's so much fear and anxiety. We don't have really great tools to actually capture the burden of this chronic disease on our patient population. Because a lot of these are soft measures, um, like exclusion from specific activities, changes in lifestyle for parents who change jobs to be readily available to their child in case they have an allergic reaction at school or on a field trip. And so this has opened the doors with a lot of hope and promise to provide an additional layer of safety when that family member is not surrounded by people who understand the impact of their chronic disease, who understand the risk associated with putting simple risk, right? Simple task of putting food into your mouth, right? And so I think that this is really an amazing step forward. It's not going to be a treatment for everybody, especially patients who really fear needles. But if you can overcome that, if you can try it, I think that many families will approach this. I hope that in the next 10 years we'll see many more choices for food allergy patients, and I can envision a period of time where we have patients switching different therapeutics, just like we have patients who switch blood pressure medications or asthma inhalers, right? And wouldn't that be wonderful to be there? So it's really a huge thanks to the food allergy community for being amazing vocal advocates for you, for your patients, for your friends, for your family members who have food allergy. Because without your voice, we wouldn't have this much interest in the research. And I'm so excited about the new allergists, the trainees, the med students who are so excited about this field because there's so much more to do. And it is a partnership between our community and scientists and clinicians to inform what is the best trial design, what are the questions we still need to answer, how can we partner together. And thank you, Jennifer, for your advocacy, for your organization, for really putting this a spotlight on this and doing the hard work of making sure that this becomes a therapeutic option that is available down the line for patients in Canada. So I think this is amazing teamwork.
Yes, well, thank you. You couldn't see it, but the chat has been lighting up with hearts and thumbs up. So um, we really thank you for your time, Dr. Chinthrajah, and we thank you for your work because we are delighted that there are researchers and clinicians like you who take this on and really want to make a difference in our lives. So with that, thank you. I'll ask you to turn off your camera and I'm going to just make a few final closing comments. Um, in terms of what's next, following this session today, you'll get a short survey through GoToWebinar that asks for your thoughts about today's webinar. Please do take a moment to do the survey as it helps us to inform our educational programming and our advocacy efforts. You can also register for our next webinar on treatments and therapies because on the 16th of May, we are going to have Dr. Julia Upton join us and talk about the ins and outs of clinical trials. And you'll learn what clinical trials for food allergy treatment are all about, including why they're important, what they involve, the different stages of a trial, and when patients can get involved and other things to consider if you want to participate in one of those. You can register for that now at foodallergycanada.ca/events. Today's webinar was supported by the Schroeder Foundation and the Peanut Bureau of Canada and made possible from donations of viewers like you. So we'd like to thank you for your participation in today's webinar. You can view a recording of this webinar at foodallergycanada.ca shortly. Please also share this with others who may benefit from this content. This now concludes the webinar.